Welcome back to Therapeutics. Now that you've had the chance to go through a fair amount of therapeutics already, I think you'll find the rest of the year familiar in structure and actually beginning to see a lot of familiarity in themes in areas we've already spoken of. I will say that the focus of the areas of women's health is an area of practice that, for myself, working in the internal medicine and critical care in an inpatient setting, I don't really see as much of as a clinical experience. But for what I know, I'm going to share with you. I'll look at the data that's here and help you walk through issues for women's health. Almost every cohort we have in PA programs have at least some individuals who have worked or volunteered somewhere in Planned Parenthood or a women's health clinic or some other area. And they can provide also a lot of resource on what practice is like. So I'd encourage you to network also with the class and your class members to build on the experiences that I'll share with you from my perspective. We'll talk about estrogens and progestins, both their uses in perimenopausal and menopausal use for women with significant vasomotor symptoms, although that use has dramatically declined in the last decade or two. We'll spend a little more time probably talking about those very same drugs as we use them for hormonal contraception. We'll talk about their risks and their benefits in general and the kind of things that clinicians need to think about for women who are using estrogens or progestins. The one area we won't spend a lot of time talking about here, but I think it's important, particularly if this is your practice area, is to looking at patients or individuals who are transitioning from male to female or female to male and the role of these hormones. And I really won't go into that in depth, but I think that's an important area of knowledge or awareness if that happens to be your practice area. So as we think about estrogens and progestins, basically these are the primary, what we consider female reproductive hormones that primarily have a role in maturation, ongoing activity, and female reproduction. If we think of the standard type of role that the pituitary has as it relates to male and female hormone function, we think of the pituitary secreting follicle-stimulating hormone and luteinizing hormone. Follicle-stimulating hormone and luteinizing hormone both stimulate the ovaries to produce estrogens and progestins. And in men, luteinizing hormone also stimulates the production, ultimately, of testosterone. If we think about the chemical structures, and I'm not going to sort of bore you with the chemical structures, but the chemical structure of cholesterol is similar to estrogens, and it's similar to progestins, and it's similar to testosterone. And so particularly as we look at estrogens or progesterones or testosterone, the specific type of estrogen, or more importantly probably, the particular type of progestin might be associated with a little bit more chemical structure similar to testosterone or the androgens. And so we'll find that the specific molecules that are used as estrogen or as progestins or as androgens, for that matter, vary in their sort of ability to have more estrogenic, more progestin, or more androgenic properties associated with them. So important in female health to really have a somewhat simplified but a framework to think of how the menstrual cycle relates to how these hormones and how these hormones are varying throughout the menstrual cycle. So for the first half of the menstrual cycle, the follicular phase, second half, the luteal phase, you'll see variations in the amount of follicle and stimulating hormone, luteinizing hormone, that actually work to regulate the menstrual cycle. As we think of estrogen itself, estrogen and premenopausal females, the ovary is the primary site of estrogen production. In the follicular phase, estrogens are synthesized by the ovarian follicles. In the luteal phase, by the corpus luteum. And during pregnancy, we see large amounts of estrogen production by also the placenta, and that's excreted in urine. In men, estradiol and estrone can be actually converted from testosterone. And what an interesting finding is that for men who take androgens, particularly, for example, illicit use of anabolic steroids for example, weightlifting and muscle mass building, a fair amount of that testosterone or androgen agent actually gets converted to estradiol or estrogens, estrogen-like properties. And so one of the things you'll often see with men who take androgens is the potential for developing, among other things, gynecomastia because of this excessive estrogen production. So the physiologic and pharmacologic effects we see primarily in females with estrogen are primary and secondary sexual characteristics. Classically, you'll also see important metabolic effects on bone, in blood vessels, the heart, liver, and the central nervous system. And interestingly, when estrogens were used commonly for peri- and postmenopausal women, particularly in the 1990s, this was very common practice. In fact, because estrogens are associated with reductions in cholesterol, particularly LDL cholesterol, it was believed that actually estrogens at the time, we thought, estrogens, they lower LDL, bad cholesterol, and so they must have a cardiovascular benefit. And it was pretty common that clinicians gave estrogens pretty commonly to perimenopausal women with the thought that perhaps it even helped their cardiovascular health. Lo and behold, is while the surrogate outcome of LDL cholesterol improved, the meaningful outcome of coronary artery disease and coronary-related deaths actually increased for women on estrogens. And the reason for that is that the estrogens themselves are prothrombotic. They increase the risk for clots. And think about if somebody's having an MI, for example, that's a clot. So we really have pretty much learned that the metabolic effects of estrogens primarily have a lot of downsides, particularly in cardiovascular health. The concerns are that they actually increase cardiovascular risks. So the indications for estrogens, there are a number of them, but clinicians are a little more hesitant about using estrogen, knowing the cardiovascular risks and some of the cancer risks we'll walk through. But when we use them, we can still use them and see them used for vasomotor symptoms of menopause. And these are usually for women who have pretty significant symptoms. They've tried other modalities. Maybe they've tried some herbal preparations like black cohosh or evening primrose, something like that, and still have significant symptoms. There's also, in the last decade or so, been a fair amount of use of phytoestrogens, which are soy-based, usually soy-based, estrogen-like chemicals. And they can be used in place of estrogens. The issue that I think a lot of clinicians don't know, or at least I don't personally know, the data for the real safety for phytoestrogens. Are they really that much safer than standard estrogen products as it relates to cardiovascular risk or certain cancer risks? And I think the jury is still somewhat out on that. Probably a lower risk than estrogens, but it may not be without risk. So in any event, vasomotor symptoms, we typically use conjugated estrogens, and we'll talk about this in a bit. If a woman has an intact uterus, we will also give cyclic use of progestins with that as well. We'll talk in a bit about contraceptive use of estrogen plus progestins or progestin alone products for contraception. And those are the two major indications that most clinicians will see in primary care for estrogens. You may see them also used for failure of ovarian development. In puberty, that's going to be pretty much limited to a gynecologist who works in adolescent health, for example. Historically, they used to use estrogens for dysmenorrhea. They could be used for dysfunctional uterine bleeding. The concern with using any estrogen or progestin product in a woman who has uterine bleeding is that you want to identify the etiology of that before you treat it. You want to rule out cancers, you want to rule out other sources of bleeding, and not just mask the bleeding, but really find a clear indication for its use and evaluate any other risks that the bleeding may sort of relate to. Androgens have an effect on acne, so estrogens could, in fact, improve acne, and in fact, we have some hormonal contraceptive products that, because of their balance of estrogen-progestin effects, they actually can, while they benefit or are effective as contraceptives, they also have the added benefit of improving acne, and so you'll sometimes see that used. Historically, for women who had unwanted hair growth, estrogens were also used for that purpose. If that's an issue for a woman who's going to use a estrogen product or an estrogen progestin product anyway, then that might be a consideration in which product is chosen. But hirsutism and acne alone are not valid indications for using estrogen products anymore. There are some clear contraindications to using estrogens. One is pregnancy. It's teratogenic, particularly if it is a male fetus. It could be more problematic. We're always concerned about the risk for estrogen-dependent neoplasms, particularly breast cancer in particular is a risk if a woman has a family history of breast cancer, particularly if their family history of breast cancer and that cancer is sort of fed by estrogen, that's an issue. Any undiagnosed vaginal bleeding would be a contraindication until you rule out the etiology of that bleeding. Liver impairment in that estrogens can impair, cause liver injury, so you want to be careful about that. And estrogens are also contraindicated in thromboembolic events. We also see that estrogens also are problematic for gallstones. They're problematic for certainly any blood clot of DVT or a PE history is a reason not to use estrogens. Estrogens also associated with nausea, so basically what we find is that many clinicians will recommend if a patient is taking estrogens or hormonal contraception, we usually recommend taking it at nighttime so that if there is any nausea, particularly early in the course of therapy, the patient might be able to sleep through it. You can also see with estrogen use anorexia, sometimes diarrhea, sometimes breast tenderness, edema. Certainly in men you'd expect gynecomastia. Headache and migraine headache is also a problem that you'll see, sometimes hyperpigmentation of the skin, and sometimes mild elevations in blood pressure. So all those are things to keep in mind. The cancer risks with estrogens, we find there are increases in certain types of cancers where others are not as problematic. Endometrial cancer risk is increased in postmenopausal women, but lower risk if they're on estrogen or estrogen progestin cyclically. But breast cancer risk is probably higher, particularly in the subset of folks who have a family history of breast cancer, particularly if it's an estrogen receptor positive type of breast cancer. So you want to be careful about that. There's also concerns for cervical or vaginal adenocarcinoma for women who, for daughters of women who took diethylstilbestrol, a type of estrogen derivative, during pregnancy, and that was done moderately commonly in the 1950s, 1960s. Estrogens are available in lots of different dose forms, so we'll talk about those. There are oral forms, transdermal, there are topical and vaginal products as well. Most of those are used for contraception, but we'll talk about the kind of products that are available. There are also a subset of type of estrogens. Those are estrogen receptor modulators, selective estrogen receptor modulators that work as estrogen agonists at some sites and antagonists at others. There are three products that are on the market. They were used much more commonly a decade or so ago, much less so now. Tamoxifen and viloxifene are probably the two that you'll see the most still occasionally used. The estrogen agonist antagonist viloxifene is a anti-estrogen at the breast and uterus and an agonist, estrogen agonist at bone and lipids. And so, at least in theory, it has the advantage of lowering risk for breast cancer, not increasing it, or uterine cancers, and improving osteoporosis. And so, maybe some effect on lipids. This agent was used pretty commonly, again, about a decade ago or so for osteoporosis treatment, but has really fallen by the wayside. We don't see it used very much anymore. It does increase bone resorption with less nausea, vomiting. We find that the risk for breast cancers with these agents probably a little bit lower. The sister drug to this agent, tamoxifen, is actually used to be a first-line agent for women with certain types of breast cancer. It's really fallen to a second-line therapy now for women with breast cancer, and we'll talk more about that in the oncology section. The other agent here, Asfina, 60 milligrams, is indicated for the treatment of moderate or severe pain due to vulvar or vaginal atrophy during menopause. And it has some beneficial effects there. But I think as a clinician, if you're working either in primary care, unless you're working with a gynecologist, you're probably not going to be ordering this. But you want to be aware of a woman who might be on it. It has the same contraindications for use as estrogens do, particularly history of estrogen-dependent cancers or undiagnosed vaginal bleeding. Also, pregnancy is a concern, a history of any thromboembolic events or hepatic impairment, all reasons, or gallstones, all reasons really to avoid this agent or stop it if those new circumstances arise. There are also agents that are more anti-androgen than these are, anti-androgen across the board. Clomiphene and tamoxifen is a little more anti-androgen, estrogen, excuse me. And the anti-estrogen properties of tamoxifen makes it really a good second-line agent for estrogen-dependent breast cancers. Clomiphene is an interesting agent. It results in some negative feedback on estrogens in the hypothalamus and pituitary, and therefore it has a role, interestingly, for affecting as a treatment for infertility. So clomiphene is an agent that has been used historically and is still in some regimens used as well for modalities for infertility based on that feedback loop. All right, those are basically, you've gone through the estrogens, and now let's quickly go through the progestins. Progestins are chemically similar to estrogens, but progestins are a group of chemicals that have more activity that looks like progesterone than estrogen. And the role of progestins or progesterone really is to act as preparing or maintaining the uterine lining for implantation of a fertilized egg. So progestin levels will be elevated during early mid-cycle, and if a woman should become pregnant, then progestin levels will continue throughout pregnancy to maintain the uterine lining. The issue is that if progestin levels drop dramatically, then a woman could start her menses. And so we see that regulating progestins will affect actually the risk for uterine bleeding, and you'll find that a drop in progestin levels is associated with the onset of menses and bleeding. Progestins, they're also synthesized by the ovaries and the placenta, typically during the menstrual cycle, and the peak of progestins is typically around the middle cycle, and then in the last week of a 4-week cycle, it drops off dramatically, causing or initiating the sloughing of the uterine lining. The effects that progestins have, primarily think of this as an agent that in high levels maintains uterine lining, when levels drop, actually sloughing that lining. It also has sort of other physiologic properties. Progestins themselves also suppress luteinizing and follicle-stimulating hormone, which renders even a progestin alone product in a slightly higher dose than the combination with estrogen used as a contraceptive. So progestin-only products are also used as contraceptive modalities. So as we think of the clinical pharmacology of progestins, we also, like with estrogens, are worried about teratogenic effects of breakthrough bleeding, of breast tenderness like we saw with estrogens, but like estrogens also could be associated with depression, liver injury, edema, a whole host of other things as well. There is some data that progestins may also have a beneficial effect on bone density, but or may not. Is kind of equivocal there. But we don't typically think of progestins as an agent to either treat or cause themselves a high risk for bone loss as well. The therapeutic uses, we're going to use them in combination with estrogens for hormone replacement and also for use as a modality for contraception. There are a number of progestin products. The most common ones you'll see are either progesterone itself, medroxyprogesterone, megestrol, or norethindrone. Those are probably the most four common, but there are others as well. And like with estrogens, we see the ovary is the primary source of progesterone synthesis, and basically will affect specific proteins in the intercellular receptors that will affect, among other things, suppression of luteinizing and follicle stimulating hormone, maintenance of the lining as well of the endometrium. We'll see that it's released during the luteal phase, and then that's that abrupt decline of progestin that results in the onset of menstruation. And like estrogens, they're very fat-soluble agents that have a fairly high first pass effect, like estrogens do as well. The indications for progestins alone or in combinations with estrogen are contraception. They can be used and particularly effective for use for irregular or hemorrhagic menstrual bleeding. But again, keep in mind that any bleeding at all needs to be evaluated carefully before you start one of these therapies that will suppress bleeding but won't deal with the underlying cancer or whatever that could be. So that needs to get ruled out first. We'll also see progestins alone or in combination as very common in virtually all hormonal contraceptives, and so we'll talk about that. We alluded just to dysfunctional uterine bleeding and dysmenorrhea, again ruling out any bleeding first. They historically have been used for other indications as well, premenstrual syndrome, but people aren't really using it for that. It has some role perhaps in endometriosis or in other circumstances like, among other things, suppressing postpartum lactation. But we'll see that for the most part, these agents, using a progestin for any of these indications, really is going to be done with a gynecologist. The one or two unusual indications for progestins in both men and women, and we sort of weigh the risk and the benefit, is for Pickwickian or hypoventilation syndrome. It's a rare circumstance that pulmonologists will choose one of these agents for that, but it has some role there. I encourage you, if that's the situation. It's really second or third line, so you don't see it used very much. The other thing you will see, though, is megestrol, used, among other things, to stimulate appetite. And it's a really quite a large dose that we use to do that. We usually limit these doses of megase in its big doses, like 400 milligrams once or twice a day. These are pretty big doses for megestrol acetate. We'll see it used for folks who don't have a good appetite. They might have cachexia with advanced HIV or cancers or something else. But we don't see that used until we've sort of explored most other modalities for stimulating appetite. The contraindications for progestins, like estrogens, thromboembolic risk, although probably the thromboembolic risk might be a bit lower with progestins than they were with just plain estrogens. We worry about any other kind of bleeding issues, cerebral hemorrhage, that could be true with estrogens as well, impaired liver function, undiagnosed vaginal bleeding. There's some question about whether or not progestins, because they're somewhat similar in chemical structure to estrogens, whether that'd be a problem for women with breast cancer. The biggest adverse effects you see, you could have thrombophlebitis and pulmonary embolism risk, and that's really the big concern, one of the big concerns you've got with progestins. You also worry about changes in bleeding when the levels go up and down, so you could have breakthrough bleeding or spotting that changes with changing dose. And there is the anti-progestin product, which was historically known as RU486, that actually induces an abortion. And so, because think about what progestins do is they maintain uterine lining, so an anti-progestin will actually cause immediate sloughing of uterine lining and therefore could be used as a abortifacient agent. All right, let's look now at some of the clinical applications associated with using estrogens and progestin. When we think about using hormonal therapy for women who are perimenopausal or undergoing menopause, we think about typically how significant the vasomotor symptoms are and weighing the risk and the benefit of using one of these agents. And so While these agents have historically been used quite regularly in women who are perimenopausal, their use has diminished quite a bit in the last 2 decades or so because of the risks associated with them, thromboembolic risks and also cancer risks. And that thromboembolic risk increases with age, and it also increases if a woman has a smoking history. And so estrogens plus smoking is a very high risk, particularly in older women, a very high risk for a thromboembolic event. And so you want to really be aware of that. We will use it, though, for vasomotor symptoms or genital urinary atrophy for women who have very significant symptoms where any other modality and everything else has been tried and the symptoms are significant enough. But you really want to explore all the other options pretty much before you look at estrogens or estrogen progestin therapy for vasomotor symptoms associated with menopause. So the vasomotor symptoms typically present with hot flashes and interrupted sleep. Quality of life declines, and sometimes that's pretty dramatic. And it typically occurs within 12 to 24 months of their last recorded menstrual cycle, and it can persist for months to years. It often causes lots of really uncomfortable to very uncomfortable circumstances for some women. Some women will describe very dramatic symptoms. Others, they find ways to sort of to get through it. The genitourinary atrophy is also another potential issue. And more often than not, if this is the primary mechanism, we'll look at either using a lubricant for a woman, if that can work as sort of first-line therapy, or if not, then seeing if there's a way to reduce the burden of the estrogen by using a topical or local or vaginally administered product, estrogen product or estrogen progestin product, that way to sort of manage them. The treatments typically with menopause are very individualized. We look specifically at what a woman's risks are, particularly their own personal or family history of breast cancer. We look at cardiovascular disease, if they had, what's their coronary risk factors. Are they a diabetic, which can increase the coronary vascular risk factors? That makes it a riskier thing to do. Is there a history of a stroke? Do they have hypertension? Do they have a history of a thromboembolic event? And then you weigh the quality of life with the symptoms that you're looking at, and have you really exhausted everything else? And then you really want to make sure that you're informing that woman of all of the risks and the benefits so they can make an informed decision and know that this is a therapy that's associated with some risk. When we decide to use estrogen, progestin, or estrogenal unopposed estrogen, as we'll call it, for women who without progestins, we'll talk about that in a minute. When we decide to do that, we really want to make sure we do that at the lowest effective dose for the shortest duration. And so we look at really lower dosing and then working our way up to higher doses if we really need them, but trying not to do that. And limiting therapy to 6 months, a year, maybe 2 years. But beyond 2 years, most clinicians try to have a transition plan to come off of these agents and not be on them longer term. The primary indication is when we use estrogen progestins is you've exhausted most other modalities for a woman and their severe symptoms. They historically also used the estrogen progestin combinations for osteoporosis. That is largely no longer the case now. The benefits of estrogen, they offer a lot. And so now we don't want to just talk about risk. They certainly will affect genital urinary atrophy and vasomotor instability. They'll have a beneficial effect on osteoporosis. We'll see its effects on lipids, which look good, but unfortunately the thromboembolic event risk is higher, and so we don't do that anymore. And for women who have a significant hot flashes in their vasomotor symptoms or mood changes, or vaginal atrophy, all of those can be improved with estrogen, which is why they're really coming to you as a clinician and asking for symptom relief. But we've already talked about the risk. Let's talk about a few of these sort of in a little more in depth. Let's talk about the cancer risk first. The endometrial cancer risk. For women who have an intact uterus, we would not give unopposed estrogen because of the risk for uterine cancer. And so if a woman has not had a hysterectomy, if they have an intact uterus, we are going to give estrogen in combination with progestins. And there's a lot of different regimens that are available. But typically, if you give estrogen alone, the cancer risk is typically 8 times higher than not using estrogen. So we don't really do that, particularly if a woman has any family history or history of endometrial cancer. But we would use a progestin in combination with estrogen to lower that risk. Breast cancer also is a concern, certainly. So we wouldn't recommend it with any woman with either a personal history of breast cancer or a strong family history of breast cancer. We'd really look at avoiding that. We also want to look at the cardiovascular risk outcomes, particularly for venous thromboembolism. So if a woman has, for example, any risk for a history of DVT or a PE, or they have any other cancers where their risk for thromboembolic event is higher, or there is any other cardiovascular risk that you worry about. Their risk for an MI is high, or they've had a CVA stroke, or they have AFib, for example, where we know the risk for stroke is higher. All those would be reasons to say no to estrogens. In addition, the other issues that I didn't sort of list in this slide, but we always think about gallbladder risk or gallstone risk with estrogens. And so estrogens are also a problem for women who've had a history of gallstones. So we want to sort of be aware of that. Other adverse effects that usually are manageable are bloating, headache, breast tenderness, and keep in mind the issue with for unopposed estrogen with unpredictable uterine bleeding, and so you want to sort of be at least aware of that. The other issues that you sort of, all the things that we talked about are sort of weighing the risks and the benefits and really lowering these risks by using lower dose and shorter durations of therapy. The other thing I'll talk about with headaches is the risk for migraine headache. Estrogens typically are associated with increased risk for migraines. And so if a woman either has had migraine headaches or after starting estrogen therapy develops migraine headaches, that's usually a reason to reevaluate the estrogen therapy entirely. So let's talk about progestins. Progestins alone, they decrease the risk of estrogen-related irregular bleeding, endometrial hyperplasia, and cancers, and so that's why we give progestins in combination with estrogens. They may offer some protection against breast cancer, although that I'm not sure that's well quantified, and they will enhance the estrogen prophylaxis in osteoporosis. But as with estrogens, progestins are risky as well. There's bloating, weight gain, irritability, and we always want to make sure we don't mask undiagnosed bleeding. In addition, they probably are safer but not fully safe for thromboembolic events or some of these other risks that we talked about. Progestins probably lower risk for thromboembolic events, though, than estrogens are. There are a number of trials that have historically been done, but here it wasn't really until the late 1990s, the HERS trial that was published in JAMA, that was really a landmark trial that identified that, in fact, even though estrogen or estrogen-progestin combinations improved the risk for cholesterol levels that were good, they actually increased the risk for cardiovascular events because of the thromboembolic nature. And so because of that, we really saw a 180-degree turn in clinical practice about estrogen use in perimenopausal women. Also, there's other data that looked at hormone replacement therapy where there was controversy about what risks there were for cardiovascular risk and breast cancer risks. But in any event, I think most clinicians really look at these trials to really sort of say, hey, there are real risks with these therapies, and let's look at avoiding them unless we really know there's a clear benefit involved. And again, lowest dose and shortest duration. Some of the ultimate risks here are summary from the multiple trials that have been done from the Women's Health initiative studies that have been done over the last couple of decades is that the risks of estrogens or estrogen and progestin therapy, combination therapies, increase heart attack risk, increase breast cancer risk, increase stroke risks, increase thromboembolic risks quite a bit, but decrease hip fractures, maybe colon cancer, and the data for dementia is unclear. It depends on who you talk with, but maybe the risk for dementia might be higher with estrogen therapy. So probably more risks than benefits here. And so, again, more reason to really be weighing those risk benefits carefully. The regimens that are commonly used for perimenopausal women, we might consider unopposed estrogen for a woman who has had a hysterectomy. There's data for that. There's transdermal or vaginal preparations. And in all these cases, we're looking at the lowest dose for the least amount of time. And you want to start looking at every 3 months, reevaluating, hey, can we lower the dose or stop? And look at limiting therapy ultimately to as short as you can. And for almost everybody, no matter what the presentation is, 5 years is considered the most you'd ever want to give somebody estrogen or hormonal therapy. We often see other regimens. There's estrogen plus cyclic progestin, and these are estrogen every day, plus they get progestin a certain window of time each month or each quarter, or sometimes women will get estrogen plus continuous progestin therapy, or some combination thereof of estrogen every day plus periods of intermittent use of progestins. For women who are on estrogen replacement therapy, and these pretty much would be not only perimenopausal women, but you could probably look at some of these same considerations for women on hormonal contraception who are younger, but would look at a monthly breast self-examination, get an annual breast exam, usually a mammography and a pelvic exam, and evaluating their any vaginal bleeding, and being careful that you're not masking something there. There are a number of estrogen products or estrogen progestin products. Here are some of the oral estrogen-only products that are primarily used as estrogen replacement therapies. The oldest agent is the conjugated estrogen or Premarin, and that's been around probably for half a century, really. And it's sort of an interesting anecdote if you don't know this one already. It's probably one of the worst marketing techniques for a brand name of a drug. Premarin was developed, or conjugated estrogen was developed from the urine of pregnant horses. And so the brand name Premarin comes from pregnant mare urine. Premarin, pregnant mare urine. I think whoever came up with that brand name of the drug should have been fired. There are vaginal estrogen products as well. These are, for example, for women with their primary symptoms are vaginal dryness or atrophy, where they've tried lubricants, they've tried other things that haven't worked. If they need a vaginal product, these products will also have some systemic absorption, so they will have risks associated with them, but it probably reduces somewhat their estrogen exposure. So they still are risky, but they're not. Perhaps they will lower the burden of estrogen use, and there's sort of some of the products that are listed here. There's also transdermal estrogen, and they really don't have all that much advantage over oral, maybe a little less nausea, but typically the advantage of some of these patches are they're convenient for women to apply. There's lots of different brand products that are available with different products, and the patches are typically changed once or twice a week. There's also a couple of daily patches or other topical forms as well. And then there are estrogen progestin combination products, and these are typically make it more convenient to do an estrogen progestin regimen in a perimenopausal woman or postmenopausal woman for vasomotor symptoms when you really do need to give progestin and not just unopposed estrogen for a woman who does have an intact uterus. There are also some progestin-only products. I'll list these here, and these might be used, for example, for someone who has significant vaginal bleeding where you've ruled out cancers, and there are a number of them. Norethindrome is sort of the classic agent, but there's a few others, progesterone products as well, that are in the market in all different kinds of formulations. What's important to recognize is that for women who are on a perimenopausal, that before we actually go to estrogen progestins, really consider that you've exhausted some of these options. And so in addition to some of the natural products that are listed here, soy, isoflavones, more often evening primrose oil, although the evidence is not great, or black cohosh, where there's some data. Those are often sort of first choices for women with vasomotor symptoms. If those don't work, the SSRIs actually have some reasonable data, SNRIs, and each of these are really considerations, and certainly in women who hormonal therapy is not indicated or is contraindicated, these offer some benefit. And I would make the argument that because of the risk of estrogens, that these agents should be really given serious consideration in all women to try these first before going to estrogen therapy. So a lot of the SSRIs or SNRIs are listed here in typical classic doses, and those really are a good first choice for lots of women. All right. From here, after the next set of slides, we'll go through our drugs and pregnancy, which will be somewhat of a review from the summer, but a little more detail as well. And let's now switch gears and talk about contraception. There's a number of abbreviations that you may see used here, and I've listed them in a table if you see those terms used in the following few slides. So with contraception, we really want to think about how often a pregnancy is an unintended one. And in the United States, depending on which data you look at, about half of pregnancies are probably unintended, and about a quarter of those pregnancies could result in abortion. So certainly an abortion is something that I think most everyone would agree would be a procedure of last resort, and could we prevent an unwanted pregnancy by appropriate contraception in the first place, is what many clinicians would sort of recommend with a patient. Now this gets into, some women and men have strong spiritual beliefs about this or religious beliefs about one thing or another, but the issue of contraception really is in the hands of the woman and or the couple to make that decision, and the clinician guides them to what is appropriate for that individual. Important, though, to recognize as a practitioner that if someone comes and asks for contraception, that it's our obligation to make sure they have an appropriate caregiver to, without delay, facilitate that for their needs for that individual. So if, for example, you on your own self have very strong beliefs about this to the negative, which aren't many of that clinicians who do, but if you do and you honor that, then you need to be clear about making sure that you don't stand in the way for the person who's asking for it to obtain it by another provider without an interruption in care. So just keep that in mind as part of our professional duty. As we look at the issues for the contraception choices that a woman or a couple have, there are a number of them, and so we kind of look at what we're doing in the menstrual cycle as it relates to that. And we think about the ideal contraceptive would be one that would be highly effective, has a prolonged duration of action, rapidly reversible if need be, has some sense of privacy for that person who's taking it, would ideally protect against sexually transmitted infection, and is easily accessible. And of course, there's no perfect or ideal contraception method, but there are a number of them that come close on most of these points. So things that will affect the choice of which contraceptive a woman or a couple will consider, first and foremost is probably effectiveness. And we need to think about whether or not, when we think of effectiveness, are we talking theoretically or actually? So, for example, you could have, in the best of circumstances, with the best adherence, a really high effectiveness rate for a a condom or an oral contraceptive if it's used and taken as it should be. But if in actual practice people miss doses of an oral contraceptive, or they don't know how to use or use a diaphragm or a condom correctly, then the true effectiveness, the actual effectiveness comes down quite dramatically. And so you need to think about how well is the individual in front of you going to adhere to this therapy consistently, know and follow directions appropriately, and that's going to affect the effectiveness of that particular modality. You also need to think about how important it is for a woman not to become pregnant. Now, many women will say if they want contraception, they want it to be absolutely that they don't become pregnant. And there's no method that you can say absolutely, positively, 100% of the time that won't happen. But there are patients for whom that's particularly important if they're taking a known teratogenic drug. So they're taking anticonvulsant therapy, they're taking lithium, they're taking chemotherapy, they're on they're on Accutane for acne. All of those are reasons that it's important that the contraceptive particularly be effective. You have to think about the likelihood and ability of the patient to adhere to therapy. There are modalities that sort of make it easier for a woman to adhere. For example, an IUD gets inserted for X period of time, and there's not a daily or a weekly process that has to be adhered to, and so therefore adherence is, in a sense, easy. You also want to look at whether the risk for becoming pregnancy and the frequency of intercourse is frequent or not. That might affect whether or not you use a barrier method because it's very infrequent versus you want to give a systemic agent. Age makes a difference, particularly hormonal contraceptives. Once women reach the age of 35, the risk for negative outcomes with contraceptives, hormonal contraceptives go up dramatically. It's particularly true if they smoke. And so age makes a difference in both adherence but also the adverse effect risk. You need to think about the practical issues of cost and ability to pay, the adverse effect profile of each of the choices, whatever conceptions, preconceptions, misconceptions a patient may have, what's their cultural beliefs, what are their spiritual beliefs, do they have other drugs on board that would interact with that modality, what's their health status, what are their habits, all of those really interplay into the decision. So there's not one right answer for any woman or couple who's seeking contraceptive intervention. There are lots of methods. And the first we think of obviously is abstinence, which if that's true, then for this individual, and they wouldn't really be seeking birth control, we would think. There is sterilization, which is a radical thing to do, so we don't take that lightly, and that's usually a choice that is pretty limited. There's natural family planning, which is probably among the least effective, the highest rates of pregnancy, unless people are extraordinarily good at that, and still it is clearly not a foolproof method. Spermicide's also not a foolproof method, as are barrier methods. Usually the barrier methods in conjunction with the spermicide is used, not just a spermicide or just a barrier method. Hormonal contraception, which we're going to focus on, and combined contraceptives are what we're going to focus on, and also the progestin-only agents we'll talk about, as well as briefly about the intrauterine devices that are available. So as we think about the normal menstrual cycle, and I think we alluded to this earlier on, we have the earlier and up to ovulation, where we see luteinizing hormone and follicle stimulating hormone levels changing. And we have the ovarian cycle ultimately for full ovulation. And what's going on in the endometrial lining is that it's building up as progestin levels maintained or pretty high. And you'll see at the end of the cycle, we see progestin levels drop, and when they drop, that's the possibility of sloughing the uterine lining. So we can pretty much see that if we suppress the luteinizing or follicle-stimulating hormones, that will affect the menstrual cycle and will, among other things, inhibit ovulation. We can also have other factors that are going to affect the uterine lining as well. There are some issues here with hormone replacement therapy, and here are some of the risks or benefits and harms per 10,000 women years. And it's kind of a way to think of what are the benefits versus what are the harms associated with hormone replacement therapy. And these are some of the same things we saw earlier when we talked about estrogens and progestins. The benefits are probably reduced fracture risks, maybe reduced colon cancer risk, unclear about what the role of estrogens particularly have in dementia, but then look at all these harms. We have coronary events, stroke events, which certainly are higher as women get older, thromboembolic events and cancer risk events. Now, this issue, here we look at the data for older women, and these older women here, this goes really beyond the window you're looking at a woman with hormonal contraception. But I put this slide here as well to show you that these are the same factors we think about in younger women as well. The effectiveness of family planning here is the most effective versus the lesser effective options. And what you'll see is across the top, those things like intrauterine devices or injectable medications are associated with higher effectiveness or less chance of effectiveness because they are there's not a daily thing that has to be done. When you start to have adherence to therapy, the pill, the patch, the ring, the diaphragm, or particularly with the barrier methods where there's a technique involved, all of those are associated with higher rates of pregnancy. And so each of those need to be a consideration when you're making a woman or a couple is making some decisions about family planning methods. If folks are using barrier methods, they often recommend barrier plus something else. The advantage of barrier is that barrier will reduce the risk for sexually transmitted infection. It won't make it zero, but it will make it reduced. Where many of the other things on the right-hand side here really do nothing to prevent sexually transmitted infections. And so the barrier method helps against HIV and other sexually transmitted infections, whereas the hormonal contraceptive patch, the ring, the implant, the injection, or IUD do nothing to prevent sexually transmitted infections. So really encouraging patients to do sort of both, particularly if there's any question at all about sexually transmitted infection. The other issues we think about, as I alluded to, is that hormonal contraception, oral contraceptives in a smoker, the risk for death and other or severe complications go higher and higher, both with age and with smoking. And so what's highlighted here, particularly you'll see with oral contraceptives over the age of 35 or oral contraceptives in a smoker over the age of 30. These are really high numbers, and so we avoid hormonal contraceptives in a smoker entirely if we can, but particularly over the age of 25, we really avoid it. And hormonal contraceptives, usually over the age of 35, in a non-smoker, we look to avoid it as well. Hormonal contraceptives first developed in the early 1960s, and those first agents were very high in estrogen and progestins, particularly estrogen, very high dose of estrogen. And so with those were lots of adverse effects, including pretty high risks for pulmonary embolism and DVTs. In the 1970s, we saw progestin-only pills started and lower estrogen and in combination products. And we then recognized the first use of postcoital contraception or emergency contraception as well in the 70s. By the 1980s, we had varying doses each week with hormonal contraception. In the late 80s, we saw there were some non-contraceptive benefits for hormonal contraception, and so we began to look at things like which agents, if a woman is going to use a hormonal contraceptive, which agents begin to have an effect on improving acne or some other factor as well. And we started to see in the 90s lower dose and lower dose estrogen containing products. We saw also some in emergency contraceptive use became more popular and actually marketed as such. We had like Plan B, emergency contraception. We'll talk about those modalities. And we also have some extended duration contraceptives and the use now of unrestricted over-the-counter sale in most states for emergency contraception use. So the indications for them primarily are preventing pregnancy, and for some products, also acne and or premenstrual dysphoric disorder. And while the agents have indication for acne or premenstrual dysphoric disorder, those two categories usually are only used when there is also an indication for contraception. There are off-label use for some of these as well. You can sort of look at those. But again, the risks associated with estrogen and progestins, at least if you are in primary care, you're probably not going to use anything other than preventing pregnancy as your choice of therapy. Otherwise, you're probably going to go get that case bumped up to a gynecologist to make an evaluation there. There are some other benefits, as we alluded to earlier on. Treatment of polycystic ovarian syndrome is one, treatment of endometriosis, reducing endometrial cancer risks, maybe colon cancer risks. So there are some other benefits in addition for some other modest benefits that are seen as some of the listed here. But these are, in general, unless there's a particular compelling reason to consider some of these, they're usually going to be evaluated by particularly endometriosis or polycystic ovarian syndrome are going to be evaluated by a gynecologist and make the risk-benefit assessment of hormonal therapy and which agents at what dose make the most sense. The risks, as we alluded to, thromboembolic events is a big one. MI risk, particularly in smokers, is a big one. Stroke, again, smokers is a big one. Over the age of 35, also an important sort of cutoff point for all these cardiovascular risks. Cancer risk in breast cancer is higher. Cervical cancer risk is higher as well. There are metabolic concerns. We see liver disease, sometimes gallbladder disease as well, particularly with higher dose estrogen. It doesn't seem like the hormonal contraceptives cause diabetes, but some patients who have diabetes, it can make glycemic control a little bit more difficult. You can also see changes in lipids. Some of those might be good, some of those might be not so good. And migraine headaches associated particularly with estrogens and also visual changes, sometimes really worried about a retinal thrombotic event. So as we look at estrogens used in combinations, typically the estrogen choice in hormonal contraception usually is ethinyl estradiol or estradiol valerate or some other estrogen product. Those first two, particularly ethinyl estradiol, is probably the agent we'll see most often used. And they pretty much are the same estrogens or have the same effects that we saw with estrogens earlier on in this lecture. They basically cause a feedback to the pituitary inhibiting follicle-stimulating hormone in ovulation, which is pretty much the main way that they work. We also talked about some of the other adverse effects that women will often have with estrogen therapy: nausea, vomiting, which is reduced when we dose this at bedtime, bloating and edema, irritability, maybe fluid weight gain, headache you've got to worry about, particularly if it's migraine. Keep an eye on their blood pressure. We also see progestins used as, we don't have estrogen alone products. We only have estrogen, progestin, or progestin alone products. And probably the most common of the agents we see used is norethindrone. There are many others as well. There are many of them on the market, and so with all of the different brands of hormonal contraception that are on the market, you'll probably see one of these progestins in that product. They're used in combination. They give, again, feedback to the pituitary, inhibiting ovulation. And some of the adverse effects we'll see are similar to what we saw with the estrogens, some of the very same things. Sometimes you'll see an increased appetite with weight gain. Sometimes you'll see central nervous system depression or fatigue or changes in libido. You could, depending on how androgenic the product is, you could actually either see hair loss or increased hair. And you could also see acne or oily skin. That's particularly true if there are more androgenic properties to them. The World Health Organization has some medical eligibility criteria for the use of contraceptives. And these are often done in a way that help you decide if there is some reason why you would avoid a contraceptive in this patient. So, for example, a category 1 is a condition for which there is no restriction for the use of the contraceptive method, where category 4 is that condition makes it unacceptable to use hormonal contraception. And the World Health Organization's category 4 contraindications include smokers over the age of 35, someone with several risk factors for cardiovascular disease, blood pressure greater than 160 over 100, vascular disease, a current DVT or a PE or a history of one, complicated diabetes with nephropathy, neuropathy, or retinopathy, liver tumors, cirrhosis, active hepatitis, viral hepatitis, surgery with prolonged immobilization, a thrombogenic mutation, ischemic heart disease, a history of a stroke, valvular heart disease, migraine headaches, or current breast cancer. All those are considered no hormonal contraception, absolute contraindications. The adverse effects associated with hormonal contraception, probably the most common one you'll see are bleeding irregularities and maybe spotting, and those are almost common, and those can be amended by particularly the progestin product, how much of it and when the progestin levels will fall. Nausea, also 1 in 5 women will get that, and we typically dose these at bedtime if we can. You'll see weight gain, mood swings, breast tenderness, headache, and maybe 1 out of 6 to 1 out of 10 women who take these products. The adverse effects, typically breakthrough bleeding. We look at assessing over a 3-month period and or considering an alternate agent depending on when in the cycle they're having breakthrough bleeding. If it's early, it's likely not enough estrogen. If it's late, it's probably not enough progestin. And we typically will look at, in breakthrough bleeding, we'll look at an agent with a little bit higher estrogen or progestin activity. Nausea, typically, again, as we take with food or in the evening. Acne, typically we see acne get worse with a more androgenic property of the progestin, and so you could select a product that has lower androgenic activity or one that's indicated for use with acne. The serious adverse effects that people think of, the classic acronym here that people have used is aches. A, abdominal pain, could mean liver problem, chest pain or shortness of breath, coughing up blood, blood clot. Headaches, severe, could signal a stroke or a blood clot, or migraine headaches. Eye problems, any blurred vision, could signal optic neuritis or a stroke again, or clots. Severe leg pain could signal a deep vein thrombosis. So all of the common things. Think of thromboembolic events, think of gallbladder, liver conditions, and then always think about any type of longer-term cancer risk, which isn't really addressed in this acronym. So there's the chart of the medical eligibility for contraceptives. This sort of mimics the World Health Organization. I encourage you to sort of look this over, and it gives you, based on certain conditions, what comorbidities would be relative, contraindicated, or it's okay to use hormonal contraception with. Again, sort of take a look at all of that, and that's really useful. It's a fairly extensive set of tables. Again, all of these, take a look at this. So again, as we alluded to a bit earlier, sometimes there's a little too much or too little estrogen or progestin. Here's what happens when you see any of these particular side effects is often indicative of too much or too little estrogen or too much or too little progestin. And so as you match up the kind of side effects, you can then look at an agent that has more or less estrogen or more or less progestin based on what you're seeing for an adverse effect. Here's an example of an older chart, but what you'll find is that you look at the products that are available and you look at whether or not they're very low estrogen or intermediate estrogen content, and whether they're very low, intermediate, or high in the progestin content. And then you sort of match up what is appropriate for that individual patient. Some of the interactions that you'll see, there are many of them, interactions with hormonal contraceptives, so you want to make sure you do a drug interaction check with them. There's a few agents for drugs for which you've seen increased effect of hormonal contraceptives. Most of the drugs that are listed here, though, clinically are not all that important, perhaps with the exception of voriconazole or the azole antifungals. But short of that, the rest of these are usually not considered a problem. Now, what I will say is what you'll see on here is rosuvastatin. Remember, though, that statins are themselves, the old term category X, are teratogenic drugs. And so when we look at atorvastatin or rosuvastatin, we need to be careful about that woman. If she really needs a statin, she should not become pregnant because these drugs are known teratogens. We have a number of agents that are probably even more importantly decrease the effect of the hormonal contraception and the risk for a woman becoming pregnant. These are often the agents that induce metabolism, and we'll see the anticonvulsant drugs listed sort of high on this list among other drugs. And so you want to make sure rifampin, another drug that's on this list, maybe isoniazid for TB as well. There's a lot of debate about whether other antimicrobials other than rifampin are problematic. Let me go to the next slide just to briefly allude to that. So whether or not antimicrobials, a course of antimicrobials is a reason for a woman to use a different form of contraception while she's on it, there are case reports, particularly with tetracyclines and macrolides and penicillins, beta-lactam cephalosporins, but the larger studies haven't seen that much of an issue. The proposed mechanism is that the antibiotics affect the enterohepatic cycling of the estrogen, and that can interfere with the level or the amount of hormonal contraception. This may be an issue for the very low dose estrogen products, but for the most part it's been largely refuted. That said, most clinicians would probably say, okay, a woman's on hormonal contraception when you start the antibiotic for the next month, consider a second form of contraception. Although that will be debated in different places, you may find where you're going to conflict that. I'd say it's just good practice to say use a barrier method on top of the hormonal contraception for that month period of time. There are lots of interactions potential. Here's a list of some of them. We alluded to some of these already. And whether or not the hormonal contraceptives have an effect on other drugs, well, certainly anticoagulants. The issue here is that they are thrombogenic. The estrogens are thrombogenic. So if they're an anticoagulant, then something's not right here. They probably should be contraindicated for using a hormonal contraception in the first place. We also see that sometimes the anticonvulsants, lamotrigine, can be affected. The anticonvulsants will affect the levels of hormonal contraceptives, but here's an anticonvulsant level that's affected by hormonal contraceptives itself. Here's another sort of set of tables that look at some issues with drug interactions. Really the bottom line is do a drug interaction check when you start or stop these agents, or you're adding another agent to somebody who's on hormonal contraceptive. The types of hormonal contraceptives that are on the market, there are many of them. There are oral agents by phase. There's monophasic, biphasic, triphasic, even now quadriphasic agents where the estrogen to progesterone levels changes during the month. There's high dose estrogen, which aren't used much anymore, low dose and then very low dose estrogen. And the very low dose and low dose estrogens really came out post the early 1960s, where we only had higher dose estrogen products that had pretty high rates of thromboembolic events. The effectiveness of hormonal contraception, if it's consistently taken with perfect use, almost 100%, but with real typical use, it's really about 92%. And adherence really wanes after the first year, and so that can go down dramatically if a woman does not take therapy. So we typically look at starting them on most packs that are made sort of have a Sunday start. And so we'll look at starting on a Sunday and then depending on how the pack is sort of developed, it might be a foil pack or a punch out or something like that. You could look at doing that. What you'll often find is that when you're changing from one brand to another brand, you usually look at completing the old pack. And usually what you'll see is there'll be either a 21 or a 28-day pack. And typically what's seen in most hormonal contraceptive packs is that days 1 through 21 are active drug, maybe in varying doses each week if it's a bi or tri or quadriphasic product. But in the last week is typically placebo. And you really do want most of the, except for the longer contraceptive products like Seasonal, usually what you'll have is a woman will have a regular menstrual cycle when the progesterone levels really drop off from the hormonal contraceptive. You also want to make sure that patients know how to take their medication, same time every day, one a day, if they miss a dose. Typically what you look at is as soon as you miss a dose, take it if it's on the same day. And you don't need a backup method, BUM, meaning backup method of birth control. If there are 2 pills missed, then you take 2 pills for 2 days and then use a backup method for 7 days, typically condoms or a barrier protective method. If you miss 2 pills in a week, in week 3 of the cycle, or miss 3 pills in the first 3 weeks, there's sort of guidelines here on what to do a little bit more specifically. But typically, if you are looking at missing those doses, then you want to make sure that except for missing 1 pill and taking it as soon as you remember, to have a backup method of birth control for the next 7 days. There's alternate things that are done as well, and I sort of refer you to these alternate methods for missed doses. I'm not going to go through it. But typically, just remember that there is a way to catch up. If you miss a single dose, a woman should know what to do, what the plan is if they miss a single dose. But if you miss more than 2 doses, then it gets a little dicier for making sure how long you need to have backup method in place. There are also some unique formulas that are dosed sort of a bit differently. There's some of those are listed here. Some of the products change their formulation over the month, and they may have more than 21 days of active drug, and placebo maybe the last 3 or 4 or 5 days instead of a full 7 days. There are advantages and disadvantages of combined hormonal contraceptive, but I think that let's talk about some of the disadvantages here. Keep in mind that they offer no protection against sexually transmitted infection or HIV. That's probably the biggest thing you need to sort of relay to folks, in addition to the adverse effect profile and the other adverse effects that are associated with hormonal contraceptives. There's also transdermal formulation, ortho-evra, and this became popular, a little more than a decade ago, And over the last 5 years or so, there's been reduced use of this product, at least for a window of time. It may have sort of resurged again. But there was some concern about varying or excessive amount of estrogen absorption with the patch and maybe an increased risk for thromboembolic events. And so, as such, some clinicians have sort of weaned away from this. But the advantages and disadvantages are sort of listed here. There's some questionable increase of blood clots. That's still sort of not is not clear. And really, because the patch is kind of a fixed dose, we usually look at not using it in women over 90 kilogram body weight, partly because we just don't know if there's going to be enough estrogen received to be effective as a hormonal contraceptive. Some women really prefer the vaginal ring. This delivers 15 micrograms of ethinylestradiol and 120 micrograms of estradiol active form of a progestin associated with it daily. Its effectiveness is similar to oral contraceptives, and that some women really like, as long as they know how to use it and insert it. It's inserted and left in for 3 weeks, and then the 4th week they remove it. But you want to be clear about how to use it and where they don't like it. There's women who really like this modality, others who don't. So there's also issues about inadvertent removal of the ring and then some adverse effects. There's also been some question about thromboembolic event risk, whether it's higher with this product compared to oral hormonal contraception. So the disadvantages are the adverse effects are similar to other regimens, but sometimes there's physical discomfort associated with wearing it, and or the potential partner might have an awareness of the ring, and so that might be a reason that some patients really don't prefer it. Whether or not there's an increased risk from thromboembolic events is questionable here. Then we have extended oral regimens. These are 3-month regimens. So Seasonal or Seasonique are the two products that we'll see used most often. And there's even a combined product for once a year menses as opposed to once every 3 months. And so basically they'll be the same dosage or varying doses over those 3 months, but then at the end of 3 months, the last week, there's a drop in progestin, and so a woman can have a once a quarter menses instead of a once a month. So as we think about progestin-only contraceptives, the indications for progestin-only product is if you have an absolute contraindication to estrogen-containing products, the patient may be a better risk with progestin. So there's a long list of things where we've seen patients contraindicated to estrogens. The progestin-only products might be an alternative for them, but I say that with some degree of skepticism or reluctance because progestins also are chemically similar to estrogens. So all of the contraindications that we saw with the estrogens are, I guess many clinicians would consider relative contraindications to progestins, but that's done on a case-by-case basis. Maybe these agents might be a bit safer in those patients. The components of progestins, there are typically 3 that are commonly used. Medroxyprogesterone comes as a long-acting Depo-Provera injectable. There's norethindrone, which is probably the most common of the progestin-containing products, and norgestrel. And they work by thickening cervical mucus, preventing sperm movement, affecting the uterine lining, and they suppress luteinizing and follicle-stimulating hormone. They're contraindicated in suspected pregnancy and active liver injury if folks can't have a GI tract problem with active colitis, which would be true for any of the oral agents, and or if they're drug interactions with cytochrome P450 inducers. If they're taking antibiotics, then it's probably safe to use a progestin. The oral progestin-only contraceptives have a higher rate of failure, a little higher rate of failure than the estrogen-progestin combinations. products do. You could start them on any day or the first day. That doesn't really matter. You could start them, but they're typically done in the same way that we see the 21 days on and 7 days off. And then the MIST protocol is typically there's a little less window of safety here in that you need a backup birth control method sooner. So there's a little less wiggle room when you miss a dose without having to start a backup method of contraception with a missed dose for a progestin-only product. The advantage is that they're effective. They're reversible when you stop taking it. It may be a bit better of a choice for women who are breastfeeding, but the progestin-only products are higher doses of progestin than are seen in the combination products, and so you see more weight gain, maybe acne, maybe more irregular menstrual cycles, and a shorter time window of efficacy if they miss a dose. The long-acting Depo-Provera, a progestin-only injection, is a once every 12-week IM injection, and its typical use is pretty effective, partly because you don't have a daily pill to take. The preferred method is to start it at day 5 of menses, but you could start it at other periods of time with a backup for the first 7 days. It can be given postpartum. It can be started either immediately with women's breastfeeding or waiting a month to 6 weeks. So you really want to make sure, though, that the patient is not pregnant. The adverse effects of Depo-Provera are weight gain and rarely severe clinical depression. You could also see some risk for loss of bone. That's really quite not clear. But the problem with this is that if you have these adverse effects, you have to wait 3 or 4 months before the drug begins to be cleared from the system. So you have to live with that injection for the effects of that injection for 3 or 4 months. So sometimes clinicians will consider, hey, you want to see how you respond to progestin-only product, so maybe trial for a month of an oral progestin product to make sure there's no problems with it, and then go in for the Depo-Provera if they've tolerated a progestin-only product. Typically, they get missed doses considered beyond 13 weeks between injections. You want to make very clear that the woman is obviously asking for this. I will say that in the 1960s and 70s, there was a track record of this drug being sort of pushed on women who, for example, needed some social supports financially so they would not become pregnant. And it was sort of pressured. Women were pressured into getting this injection to not become pregnant. And that is considered highly unethical to do that. And so you really want to be clear when you're looking at using a product like this that it's really, you've explained all of the options to this patient, to the woman, and make sure that it's really a choice that the woman is making freely and is not coerced into doing. There are also intrauterine devices. These are very popular in Europe and other parts of the world. And they kind of had a bad track record here in the mid-80s, late 70s, mid-80s, with a product that was associated with a lot of pelvic inflammatory disease, the Dalcon Shield, which is no longer on the market. But I think most clinicians currently now see intrauterine devices really as a very common modality. And the issues are that they're highly effective at preventing pregnancy. There are a couple of different products that are on the market, and they are somewhat reversible in the sense that when you take out the intrauterine device, usually the woman can become pregnant again over a period of time. But it's really considered a choice when you're looking at a woman who wants pregnancy protection for at least 2 years or more. So if you've got somebody who is not really sure when they want to become pregnant, maybe hey, I want to not become pregnant for the next 6 months, but I want to start a family after 6 months, this is not the choice for them. There are two different products. One that we think of, one is a copper IUD, and that it works primarily as both a spermicide, and the IUD itself is a device that really makes it difficult for a fertilized egg to impregnate into the uterus. And so it's really, they're highly effective, and the effectiveness rate probably rivals surgical intervention. There are some contraindications to using them, certainly if a woman's pregnant. The other issue we think of these are if you've got endometriosis or have had or a risk for any type of pelvic inflammatory disease. These agents are often a bit more problematic and so considered relatively contraindicated. There's also progestin intrauterine device or intrauterine system, and these are, again, preventing implantation by a foreign object in the uterus, and also the progestin affects cervical mucus, which inhibits sperm motility as well, and again, highly effective in preventing pregnancy. The contraindications are listed here as well, some of the same ones we saw with other IUDs. The adverse effects you really need to think of are a late period or abnormal bleeding, abdominal pain, particularly with intercourse, infection, particularly we worry about pelvic inflammatory disease, sexually transmitted infections, any type of not feeling well, sepsis kind of scenario, or if the markers for the IUD placement are amiss. So you really want to be aware of that. The other issues with all of these things, except for barrier protection, particularly condoms or female condoms or male condoms or female condoms or diaphragms, except for barrier devices, really these other modalities offer no protection against sexually transmitted infections. And probably of all of them, the male condom is probably the most effective as a barrier method for reducing the risk of sexually transmitted infections. I'm even afraid to say preventing, because preventing is not true, but reducing the risk dramatically is true. So there are advantages and disadvantages of the copper IUDs are listed here, as well as the progestin IUDs or IUSs, and they're sort of listed here, the advantages and disadvantages of them. There's also has been on the market, and it pretty much is not going to be seen, I don't think, in primary care, but you would see this in a GYN office, are implants. And these are usually a long-acting progestin implanted under the skin in some way that will deliver a continuous release of drug for a period up to 3 years. The good side to the implants is that they don't require a patient to take a pill every day. The bad side of them is that when you want to reverse the effects, you have to remove the pellets or the implants. And if there's trauma to the site of injection, it may be difficult to get those pellets back. So there's been a long-standing concern, potential concern, about the use of these implants. And so I think it has a limited role for where they fit, but for the right patient, it might be the right thing to consider. We also have to think about emergency contraception, and these are for women who have had intercourse either voluntarily or if they've had a sexual assault. And they will, if they're given immediately after or within, ideally within 48 to 72 hours after intercourse, that they will offer some protection against pregnancy. The farther out that is post-coitus, the more likely it's going to be ineffective. So the longest window we look for these regimens is 120 hours post-coitus, but the sooner the better. So the typically modalities are looking at one of these products, and as the time is closer to coitus, the more likely it's going to be effective. The farther away we are, the less likely the efficacy. The preferred method now probably is one of these products like Plan B, which is a progestin-only product, and it comes really as a ready-to-go packet. and there's availability of getting this over the counter. In many states, this has been available for a long time, and so there's a series of questions the pharmacist would ask the patient, but they could get this over the counter and available to them depending on their age and state. The adverse effects associated with it, again, like we saw earlier, not of nausea and vomiting, and maybe changes in menstrual cycle, but these are really the first line agents we look at now is something like Plan B. There's also some other approved options from the FDA, progestin receptor modulator that's been used. Ella is a possibility. You could also look at an IUD being inserted within 5 days, but that requires an in-office visit. And then RU486 is at least a theoretical concern. I will tell you in practice, I've not been involved in a pharmacy that has that routinely stocked, but that might be stocked in a GYN office. There are medical eligibility criteria that the MMWR from the CDC offers, and I'd encourage you to sort of look at that. The latest version that's been published was in 2016. There are also multiple guidelines that the CDC has that I'd encourage you to sort of look at or have available to you, particularly if your practice is going to include contraception. There's issues that recommendations the CDC makes for women who have bleeding irregularities while using a contraceptive, so I'd encourage you to at least look at which category of patients who has what and how to manage that situation. We have issues for IUD management, particularly if the patient has pelvic inflammatory disease. We have recommendations for late or missed combined oral contraceptives, more or less what we described earlier, but this is sort of short and sort of lends itself to a chart that might be on your practice wall. There's also issues for what to do if the hormonal patch falls off, or what to do with a vaginal ring if it becomes dislodged. There are some drugs to look at. Basically, just be familiar with some of the contraceptives and estrogen